Okay, so before you start the procedure, it's important to have everything ready, including rapid sequence intubation drugs and laryngoscopes and everything you'd use for intubation, just in case anything happens during the procedure where you have to intervene. One question we commonly get asked is what sedative we should use to help facilitate the procedure. The reason we're doing this procedure is because someone has a really difficult airway that we think it's too dangerous to give them rapid sequence intubation. So the reason we're doing this is because we want the patient to protect their airway as much as possible and follow commands. So we prefer to use no sedation if possible. That's why we're going to be doing such a meticulous job at topical anesthesia. I think it's really important to coach your patient through this procedure so that they know what's coming and aren't surprised by anything. And the goal is to use no sedation at all. If you're going to use a sedative, use midazolam as anxiolysis, because that allows the patient to still follow commands and just be a little relaxed. We think ketamine is a bad choice for a sedative here because it often results in dissociation, where they are not protecting their airway in the same way, and they're not able to follow commands, and sometimes it can cause some increased secretions during the procedure. So some question whether we should use a special nasal tube that has a built-in permanent curve to it to make it easier to connect to the ventilator. And we find that harder to pass the scope through and unnecessary for when you're doing this procedure for emergency patients. When you're deciding which endoscope to pass through, since we're using a 6.0 tube, you really want to use the smallest endoscope possible. We prefer something with like a 3.8 millimeter outer diameter. Even that still requires some lubrication to get through, so you're going to have a much easier time using the scope when you use a smaller endoscope. When choosing which tube to use, it's more comfortable for the patient to use a 6.0 tube. We prefer to use a flex tip microlaryngeal tube. This has a nice soft bevel. It is 6 millimeters inner diameter and is an extra 5 centimeters longer than usual, so you have enough tube coming out of the nose, so you don't have to hub the tube to the nose. It's also nice to warm this tube in some water, so just get a container with some hot water and warm it in there to make it more flexible to make that passage easier. One of the most important considerations when doing topical anesthesia is using the appropriate dose. You want to be meticulous and generous with your topical anesthesia to get both the nose and the back of the throat. And the Difficult Airway Society recommends a maximum dose of 9 milligrams per kilogram of lidocaine. This equates to about 15 grams or mLs of 4% lidocaine that you can give to your patients as long as they weigh more than 67 kilos. That's usually more than enough to anesthetize the nose and the back of the throat. All right, so the first step is to vasoconstrict the nose so that it opens it up, prepare it for tube passage. So this is oxymetazoline. You can use phenylephrine as well. You can either apply it or you can have the patient apply it into the nose they're breathing out of a little bit better. And you can be pretty generous with this oxymetazoline. Okay, so the next step is numbing the nose. We like to use 4% lidocaine cream. This is a 5-gram tube that has a total of 200 milligrams of lidocaine, and you just snort it in the nose and it coats the whole nasal passage to make it comfortable to dilate and then place a tube. You can either do this or the patient can do it depending on the patient's preference. So the next step is to dilate the nose to prepare it to be big enough to comfortably accept an endotracheal tube. You need some lubrication, and then you need a pinky finger to dilate. You can really dilate until the pinky finger is all the way to the MCP knuckle, so pretty far in. And again, depending on the patient's preference, either they can do it themselves or you can do it. A lot of patients like to be in control of the procedure because it just gives them that autonomy and it feels better to them. And the finger goes in slowly. So the dilation is probably a 2 to 6 or 7 minute procedure as you slowly get deeper and deeper in with that pinky finger. You can sort of feel the nasal mucosa giving way as the finger gets deeper in there. So the next step is to numb the back of the throat, the base of the tongue, the epiglottis, the periolaryngeal structures. We like to use 4% aqueous lidocaine for that. We already used 5 grams in the nose, and anyone more than 67 kilos can get up to 15 mLs or grams of 4% lidocaine. So that means we have 10 more available to use here. We're not going to use all 10, maybe use 2 or 3 here, and then save some for the scope afterwards. And we also use this flexible atomizer. This is called the magic atomizer. And you can just draw it up straight up using the atomizer. Okay, and you want to just put a little bend in it because you're aiming to get the base of the tongue, the epiglottis, the vocal cords, all those periolaryngeal structures, but you're doing it blindly, so you don't know exactly where you're going, but you just want to get some anesthesia on there before you introduce the tube and the scope. Have the patient open up wide and stick out their tongue. And they're going to cough and gag a little bit. Say, ah. Good. Sometimes this will induce gagging or rarely vomiting at the moment, but usually just spitting up. Okay, the next step is to insert the tube into the nose. This is a size 6.0 tube, so a little bit smaller because it is much more comfortable for the patient. And you want to advance the tube until it's hovering right above the vocal cord, so about 12 centimeters or so as it exits the nose. And again, you can advance this yourself or have the patient. Sometimes patients really prefer to be in control of that. Okay, so you advance this obviously directly perpendicular to the face along the floor of the nose. Slowly, and coaching your patient here is critical. And every now and then, we try to do this without sedation. The reason we're doing it without sedation is because if you're doing an awake intubation, it's because it's on someone with a really tough airway. And if they have a tough airway, you want them to be in control of their airway and able to follow commands. So if they're dissociated or too sedated, they're not going to be able to follow commands. So if you need a little help, you can use some midazolam. But we avoid the use of ketamine. We think that's one of the worst drugs you could use in this situation because half the time your patients are going to become dissociated and not be able to participate in the procedure. Okay, so this is the scope we're going to be using today, 3.8 outer diameter scope with a luer lock adapter that goes right here so you can administer local anesthesia through the scope when you're hovering above the cords. Okay, so the next step is to insert the scope into the tube. The tube should be hovering roughly above the vocal cords. Helps to put a thin layer of lubrication on the tube to help it pass through the tube easily. And as we are actually hovering right above the vocal cords right now, so the tube is in a good spot. And he has some anesthesia in the back of the throat near the laryngeal structures, but we want to make sure he's really numb before we try to advance a tube and scope. So the next step will be attaching some 4% lidocaine through a syringe. So we've got our 4% lidocaine here attached through the luer lock adapter. This will go through the scope and basically go to where you're aiming on the screen. So I just want to center the vocal cords in my field of view here. And when this happens, this makes the patient cough a little bit, which is a good sign that you're getting into the right spot. So I'm going to put in maybe 1 ml here. Sometimes they're already going to be reasonably numb.
Yeah.
And we're going to put just some that we can see hitting the vocal cords. So I'm going to get even just a little bit closer because it helps to have a little bit in the trachea. And again, that really helps pass the tube, really helps pass the scope. We want it to be very comfortable for the patient. And it does help to have them inhale as well while you're squirting the lidocaine so that they can get as much into the trachea as possible here. So now we're between the vocal cords, and go ahead and breathe in Okay, now we're in the trachea. You can advance the scope down the center of the trachea to near where the carina is. And then at this point, your assistant can advance the tube gently over the scope. And this will be to about a depth of about 28 centimeters or so. But you can actually use your scope to assess. We go a little bit deeper there, and then we'll pull the scope up. Okay, we can check the depth of the tube. Actually, a little shallow still. Yeah.
That's your scope.
Okay, at this point you can remove your scope. You can inflate the cuff. And your patient is intubated. At this point, oftentimes it helps to now give some sedation so that they're very comfortable. But if you've coached them through it really well and given really good topical anesthesia, they might not need aggressive sedation at this point. It really depends on the clinical scenario for you. But this is a good way to intubate your patient while keeping them completely awake without any sedation at all.